So we're going to continue our lecture on exercise prescription. And we introduced this very generic framework for an exercise prescription and went through the physiological benefits of the warm-up and what that would give to a patient and why it might be beneficial to include that time as part of your exercise prescription. Now let's get into the meat of the prescription, which is the conditioning phase, which can be a variety of different activities that would all fall under the general heading of exercise. So, as it says in your notes, muscular performance is the muscle's ability to do work. And that's a really kind of general, generic term. We really want to think about when we prescribe exercise as what do you specifically want to accomplish? Because when you prescribe exercise, you want to create a physiological adaptation with the goal of making a change over time. So we are not just blandly or without thought just telling someone to exercise in this general form, but rather very specifically, we are prescribing a physiological load to induce a change over time. So when you talk about trying to improve the muscle's ability to do work, you want to make sure you really are specific. But what type of work are you referring to and what would specifically benefit your patient? So when we describe strength, we're really describing the maximal force a muscle or a muscle group can exert, right? Strength is the maximum force a muscle or muscle group can exert. And having appropriate amounts of muscular strength is essential for injury prevention and for normal functional movement. We will have many strength goals for our patients. Endurance is the ability to perform repeated muscular activity over an extended period of time. The ability to perform repeated muscular activity over an extended period of time. So endurance type of muscular performance is much more functional for the completion of ADLs and maybe a lot of what your goals are that you're actually trying to accomplish. You have to be really careful as physical therapists because we often use manual muscle testing to assess strength, and then we apply that kind of more of an endurance type of activity. We really want to make sure we're understanding the difference between the two and prescribing exercise to address the needs of either strength or endurance. Power is the last one that you can see on your slide here, and that is the ability to generate large amounts of force over a very short period of time. So power, as you can see here, is the ability to, jump high over a box, a big box jump for an athlete. But power is also the ability to catch yourself when you fall. Can you generate that force really quickly? Do you need time for all that force to generate? Is that really very functional? There's a lot of power that comes into our daily lives. So when we prescribe exercise, we're going to choose what type of muscle activation we would like to prescribe. And I know you all know what these different types are, isometrics, isotonics, but which type is best for your patient? So isometrics might kind of sound or feel like a little bit of a puny exercise, but they offer a huge range of advantages for us as physical therapists. For one, you can target a specific spot in a range of motion. Sometimes people have a weak spot in their range of motion. They'll just get into that one spot of their arc and they just have no strength there. You can get them right into that spot and then do the activation in that weak area and really target that section of the range of motion. You can work in a pain-free range. So you can start muscle activation in a way that doesn't induce pain, so they can actually have some muscle activation benefits. You don't have to wait until they have their full range of motion and pain-free. You can actually generate a greater total amount of force when you compare an isometric to a concentric contraction. So isometric is a zero velocity contraction, and we generate the greatest amount of force at zero velocity. So when it comes to overloading the muscle, you can actually generate a greater amount of force with an isometric. Another really big advantage of isometrics is that you can strengthen the muscle without undue stress on an injured component of the joint or surgically repaired tissue. So, isometrics are really the muscle activation of choice after a recent fracture, where you might not yet want to be straining that bone healing, but you can get muscle activation starting. After surgical repairs, especially when there's restrictions on movement, they can start strengthening around that joint in a safe way because an isometric doesn't change the length of the muscle. Another advantage is it's beneficial for super weak muscles, like muscles that are less than a 3 out of 5 can benefit from an isometric. It can also be combined with manual therapy, and this gives you so much power when it comes to the benefit of a PT working with their hands. If you're doing some range of motion, you could add isometrics in along the way to target different sections of the range of motion. You can feel, what they're giving back to you when you're doing a manual resistance on an isometric. It gives you a lot of power. Another advantage to an isometric is it does have some analgesic properties. There are reports that there's reduced pain for up to 45 minutes after doing an isometric. This can be really helpful when someone is dealing with tendinopathies, that there is actually a reduction in pain following the performance of an isometric. Some disadvantages to an isometric is you aren't changing the length of the muscle, right? So you're stuck. You're really only getting that benefit kind of at the area of the range of motion for which you're strengthening. Strength gains are basically limited to about 20 degrees within the angle the isometrics are performed. So you're not getting the full range strengthening of the muscle. When it comes to prescribing an isometric, what do you tell the patient? How hard are they supposed to push? What is the force? What is the intensity of this exercise? We typically, when you document an isometric, even when you're describing it to a patient, we're often describing it as a percent of maximal output. And that helps you determine how much force they're generating. This is written out in your notes for you, but you can see that you have to really be between 66 to 100% of their maximal isometric output to be making strength gains with an isometric. So if your goal, the physiological adaptation you would like to induce, is to increase strength, you do need to be doing these at a relatively high force output. In that range between 35 to 66% of their max output, you do see some gains, but the progress is incredibly slow. So there might be times when this is appropriate given all the things in the background of your patient. But if you are not getting up, a close to 70% or higher, any progress you make will be incredibly slow. I put the point number 3 in here because this is probably one of the more common things patients would say. Most ADLs produce periodic tensions of around 20 to 35% of maximal output. Now, what does 20 to 35% get you? It helps you maintain strength, but this is not going to help increase strength. The number of times I had patients come back after I gave them this full exercise program and my spiel and my you-rah-rah, and they came back and they said, well, I didn't do that, but I've been using my arm a lot more, like when I'm cooking, and that is not going to give them strength gains. That's good for functional, what have yous, but most ADLs aren't going to generate force much greater than 35%. So if they come back to you and say, I didn't do the exercise you told me to do, but I've been using it more, you can say that is great, but you are not going to build strength that way. You need to overload the muscle to get strength. The last little point you'll see in your notes is just a reminder to really be cognizant of how fast we lose muscle and muscle strength when a muscle is no longer being activated. If a muscle is immobilized, strength losses can range between 8% a week to 5% per day when someone is in a cast and immobilized. So we want to keep these patients moving. That's why there's a huge push to get them out of cast as soon as you can. doing early isometrics, even if they're still casted, to have some maintenance of strength, even if you really can't increase strength. But the goal there is to prevent the atrophy. All right, so how hard should they push? Hopefully they're getting between 66 and 100% of their maximal output to get a strength benefit out of an isometric activation. How long should they hold that that contraction? This is a graph looking at the relative tension in the muscle over time. And you tell someone, do a maximal isometric activation for as long as you can. And you see that they stay in that high range. Ooh, red on red, that's not very helpful. Right? They stay in that high range really only for the first little bit, 5 seconds. Once you get to around 6 seconds, you're starting to cross down below that 70% threshold. To make significant strength gains, you should be having an activation that's about 70% or greater, right? So if a maximal isometric activity, you lose the force as you hold it, there really isn't a huge benefit to telling someone to hold an isometric for 30 seconds because their force is so petered out, they're no longer getting overload, right, at this point. They just have a fatigued muscle that isn't activating a whole lot. The kind of ideal time in a textbook standpoint is about 6 seconds. 6 seconds is the ideal time where you can get maximal tension at a percent of relative tension that provides that stimulus for strength gains. We typically say somewhere between 5 and 10 seconds, I think, because it sounds more normal. Just say 5 to 10 seconds and 6 seconds. But 5 to 10 seconds is more than enough for an isometric hold. Then let them rest, regain that strength, and do it again if you really want to have the overload for your strength gains. Okay, so how about an isotonic? When would you have them moving through their range of motion? So isotonic offers some pretty obvious advantage. You can potentially strengthen through the whole range of motion. It's really, easy, cheap equipment. You can have people doing soup cans at home. Dumbbells are very inexpensive. So it's a very easy type of exercise to prescribe. The disadvantages is that you have varying resistance through the range depending on the tool that you're using. And we'll talk more about this in lab, really the variation between a dumbbell and like a TheraBand. Another big disadvantage is that an isotonic activation typically has an eccentric phase. So an eccentric phase, right, is when the external torque exceeds the internal load of the muscle. So it's a lengthening of the muscle. The eccentric activation is much more likely to cause soreness and damage in the muscle. So that is a disadvantage because of, causing your patient pain, potential compliance with the exercise program if it's uncomfortable. And most isotonically prescribed exercises have that phase. So this is a good place to just kind of dive in and talk about that delayed onset muscle soreness, which is what I was referring to when I said that an eccentric activation is more likely to cause pain and soreness. So this cartoon really shows the delayed onset muscle soreness. You do the nice big workout, you get super motivated, you lift your weights, somewhere between 0 and 24 hours, you're still feeling really good, right? Like no pain, everything's going great. You think you're kind of Superman. And then right around that 24 hours and peaking around 48, you get pain and weakness right in the muscles that you had used during your activity. And this is delayed onset muscle soreness. I think it is now largely well known. I think over the last couple of years, I haven't had many students that still held on to this old belief, but long time ago, people believed that delayed onset muscle soreness was from lactic acid that built up in your muscles, and all that lactic acid caused all this pain. We know that is not true, and that the true origin of delayed onset muscle soreness is damaged cells within the muscle. When you overwork a muscle and strain a muscle, you damage the cells, which causes the release of histamine and prostaglandin and bradykinin. Hopefully these words sound very familiar at this point. This is the inflammatory response. Same inflammatory response I beat you over the head with in pathophys. I think you got a little bit more of it in physical agents, hopefully. But this inflammatory response is going to increase the permeability of the vessels, which means you're going to have localized edema in the muscle. That fluid's going to increase pressure. It's going to cause pain. Your pain nociceptors are sensitized by the presence of prostaglandin, which makes that pain even more severe. So delayed onset muscle soreness is simply an acute inflammatory response within the muscle. Now, where does it come from? And why did I throw out so casually that the eccentric phase is much more likely to cause this? You can get DOMS from a multiple of different types of muscle activation. The reason eccentric makes you so vulnerable is because it is the lengthening contraction, right? As the external load exceeds the internal torque, you're literally tearing actin and myosin apart, and then it's cross-bridging, and you're tearing it apart and it's cross-bridging, and that is the mechanism of the force generation. So one of the primary hypotheses of delayed onset muscle soreness and why it's so prevalent in eccentric activation is this popping sarcomere hypothesis. So on this side of the slide, you can see a whole bunch of sarcomeres. And in an individual skeletal muscle, the alignment of the sarcomeres is not uniform. Meaning, this sarcomere here has very poor overlap of actin and myosin, where this guy has really good overlap. Like, look at all those binding sites that they could be hanging on really strong. If you start a lengthening contraction, right, you start pulling apart, which of these two sarcomeres is going to be stronger or more likely to resist that activity? Obviously this guy here, right? This is going to be the stronger because there are more cross bridges, and force is directly proportional to the number of cross bridges. So if you have sarcomeres lined up and they aren't completely uniform and matched up in terms of their actin and myosin cross bridges, well, then the weakest sarcomere is going to be the one that gets disrupted. And when you have a disrupted sarcomere, it's going to put a greater strain on the neighboring sarcomere, because now this guy has to carry more of the load if sarcomere A has been disrupted and torn apart. It's no longer contributing to the force, which puts a greater load on B. And what you start to do is that you start to get shearing happening within the muscle. It's a non-uniform lengthening. So when there's weaker sarcomeres at different points along the myofibril, this shearing action will happen across the myofibril, which can expose membrane and T-tubules and cause muscle damage. So the non-uniform lengthening and the fact that you have sarcomeres at different phases in their length-tension relationship causes damage within the muscle and can increase the damage, which would increase the inflammatory response. The figure on the right shows the comparison between the amount of pain that comes when a eccentric load was done, and the open circles here is a lowering step using only one single step, and the closed circles are when they lowered 2 steps at a time. So they had a greater drop, right, a greater range of motion to lower the limb. So it would be a more intense exercise. And days after the exercise, you can see that the more intense eccentric load induced a much greater DOMS, delayed onset muscle soreness. So the theory, the popping sarcomere is just a hypothesis. The inflammatory response within the muscle is the cause of the inflammation. What exactly causes the damage and the inflammatory response is still kind of in its hypothesis or its birth phase, but we do know that we are getting micro damage within the muscle. So you can think about this when you are prescribing an isotonic in that you can break that activity up into its concentric and eccentric phases. And we will talk about this in lab, because you may find that you don't want to strain a muscle with an eccentric load, and maybe you only include the concentric phase of that activity. On the flip side, we'll talk about how an eccentric contraction can actually generate a higher total force output. So there's times when you want to exploit the eccentric phase to make strength gains, because you can actually increase the load to a higher degree than you can with the concentric. So we'll talk about this, and you guys are going to explore this in lab when you start talking about prescribing therapeutic exercise. But it is important to always keep in the back of your mind that when you provide overload, you can cause micro damage in the muscle, which can lead to DOMS. Of the types of muscle activation you might pick from, the eccentric activation is the most vulnerable to the inducement of muscle damage and the subsequent DOMS. Okay, so then the different muscle activation types. Within the realm of these isotonics, you can do closed versus open chain. And I think you guys are pretty good on closed and open chain, right? Closed chain, the distal segment is weight bearing. The big advantage in therapeutic exercise world when you're prescribing a closed chain exercise is it is highly functional, especially lower extremity, right? Most of our activities are closed chain. The other really big advantage is that a closed chain exercise provides the most joint stability. Because if your distal segment is weight bearing, you are going to have a greater activation of agonist and antagonist across the joint, which will provide a greater stability and less shear stress on your joints. And that's going to come into play when you have a vulnerable joint, when you have an acute inflammation, and you want the most stability, the less strain on a joint as possible. Closed chain can get you there. The big disadvantage with a closed chain activity is that you're using the entire kinetic chain. So because of that, stronger muscles can compensate for weaker muscles. So a lot of times in PT, we really identify a specific weak muscle or a specific weak muscle group. When you're doing an activity that uses the entire kinetic chain, those patterns of compensation can take over, and it might be harder to get the patient to activate the specific muscle group you are trying to target. So really being very vigilant and watchful for compensations and making sure you are actually getting the muscle activation that you think you are with the exercise prescription that you have. So open chain is obviously seen here on the right on the picture. That's when the distal segment moves freely in space. Advantages to open chain: you can start doing strengthening before a patient is weight bearing, which is huge. We have a lot of times when we're not free to weight bear, we can start strengthening. It is much better at isolating an individual weak muscle. So it's much easier to target the muscle that you want and get them to do it. The big disadvantage is that you have the least amount of stability at that joint. So it puts the joint a little bit more at risk. Okay, I like this picture. Always makes me laugh, because the more I think, the more confused I get, which is how I feel my entire life. The more you learn, the more you realize what you don't know. So we know all this cool stuff about physiology within the skeletal muscle, how it contributes to force output. We know about all these different ways we can activate the muscle, but how do we actually make a change in that muscle? We said the whole point of an exercise prescription is to induce a physiological adaptation to induce change over time. We're trying to make a difference. So you want your patient to go from skinny dude to stronger dude to super strong dude, or dudette, as the case may be. How much weight should you prescribe? So the simple answer to that is you need overload. The load or resistance must provide a greater stress than the body is used to if you're going to induce a physiological change. If you do not strain the muscle greater than what it's capable of doing right now, no change will happen, right? That's the example of the patient who comes back and says, oh, I'm just using my arm, my ADLs more. Well, you might be able to maintain strength to a certain degree with that, but you aren't going to increase strength. So I again really encourage you, when you think about prescribing exercise, is to really just visualize that doctor's prescription pad where they write out what drug they're giving, what is the dose, how often are they taking it. If a doctor prescribed a pill and just didn't give the proper dose, right? Gave way too low of a dose, would you expect that medicine to have any effect? Absolutely not. If we do not give our patients enough exercise, they will fail to see any benefit from physical therapy. So even though the doing of it can take a little kind of you rah rah cheerleading, selling them on what you're doing, you really have to get them into that slightly uncomfortable place where they're working at a higher load than they're accustomed to in order to increase their muscular fitness. If you still are picturing that MD prescription pad and they just give like double the amount of medicine the body's supposed to have, way too much of a drug, well, there's going to be like so many side effects to that drug, right? It's going to be awful, and it's going to hurt them when they're going to get nauseous, and they're going to get rashes, and I feel like every drug on TV calls erectile dysfunction. So that's all going to happen, okay? So too much drug, bad thing. What's going to happen if you provide too much exercise? Well, they're going to get pain, right? They can get exacerbation of their injuries. They can get swelling. So we have to also be cautious not to overprescribe, okay? More is not always better. And sometimes that can be really hard to find that balance. So how do you choose the correct load? Well, we do a strength assessment, right? We have to figure out what are they walking in with, what is their strength that they have. Most often clinically, as PTs, we do a manual muscle testing, which has some inherent flaws, but it does give you a pretty good, quick assessment of what's going on with their strength. In most exercise physiology type exercise prescription worlds, they will assess a 1 rep max, which is your 1 RM, the maximum amount of weight one can lift one time using a proper form. You can actually do that, by increasing the load and seeing what someone's 1 rep max is. There is formulas that you can do, which is provided here. You certainly do not have to memorize this, but I want you to know that if you prefer to have something a little bit more quantitative than the manual muscle test, you can use a 1 rep max. Some clinicians prefer a 10 rep max, as it's a little safer than doing the 1 rep max with someone who's injured. But you'll find on your clinicals, or you already have experienced in your life, is that a lot of times clinical assessment involves a strength assessment where you just see how many reps they can lift with a given weight, and then you make your adjustment from there. So it's nice and handy, and the textbooks love to use percentages of 1 rep max, and it gives you an idea of a kind of a common language. But when you get out into the clinic, a lot of times you're going to just see what they can do and make adjustments, always keeping in mind that you need them to do more than they're currently accustomed to if you're going to make a physiological change. The next really important concept to hold in your mind when you're prescribing exercise is the SAID principle. That we have a physiological response in the body where we will see a specific adaptation to imposed demands, meaning the exercise or type of training that you're going to give your patient is going to be specific to the type of activity they're performing and the muscles that they are using. So in this example, if you have a patient who is ineffective at doing a sit to stand, and that is impacting their life, it's impacting their independence, it's impacting their ability to get discharged to home versus a rehab setting, and you want to improve their sit to stand, which of these two exercises do you prescribe? A bicep curl or a leg extension exercise? This one is obvious, right? This one should feel obvious, but it gets lost all the time once we get into more complex movement patterns. Of the two, it's the leg strengthening that will have the most specific advantage to the activity of sit to stand. A person comes in and they want to improve their golf swing. And you have a choice between a straight shoulder flexion activity or creating a diagonal kind of D1 movement pattern. Which of these is more specific? Obviously B, right? You're following the pattern of the swing rather than this very kind of planar pattern. What's the speed that they pull that on, right? If they need to be able to do a power, an explosion golf swing, do you have them do this exercise slow and controlled as long as they want while you guys chat about the Packer game? Or do you try to simulate the activity? So the said principle has just as much to do with the movement pattern and the muscle group that you're activating as it does the type of muscle activation. And what I mean by that is, are you going for pure just strength? Are you working towards endurance? Or is your goal power? And if your goal is power, then you need to have them doing their exercise prescription with explosion, right? High amounts of force in a short period of time. Always, always be specific to the movement pattern, to the muscle group that you're using, to the energy systems that would be required to make that muscle activation happen if you want that carryover into your ultimate goal. So if you're trying to be specific and you might have either a strength goal or an endurance goal, how do you prescribe for that purpose? Well, if your overall goal is strength, in general, you're going to want a higher amount of weight and a lower amount of repetitions. This is written later in your notes, but if you'd like to have it here in this part, you have to be at least 60 to 70% of your 1 rep max for strength, and then do 2 to 4 sets of 8 to 12 reps. Seeing how they tolerate it, seeing what they are capable of. There are recommendations that when you're working with older adults, that you might have a lower percentage of your 1 rep max. But if strength is your goal, you want a higher weight and lower reps. If endurance is your goal, you want less total weight, but much higher repetitions. So less than 50% of a 1 rep max, maybe 15 to 25 reps at a time, really high numbers. Those are kind of harder to talk people into because it gets a little boring, but it's really beneficial because so much of our endurance activations are more functional. So we certainly do get some strength and endurance goals that overlap, especially when you're in that more mid-range between the two, where you can get the benefit of both. But if you really are trying to get the maximal benefit of one or the other, you want to push yourself to the extremes of those two. So last one we mentioned is power. That's, incorporates both strength and speed. This is a really important component to an exercise prescription that I think is obvious in the young and gets neglected or forgotten in the older people. And we need to be able to generate force in a short period of time. I gave the example earlier of when you trip and fall, you have to be able to have an explosive amount of force to kind of catch yourself so you don't fall down. We need to incorporate some component of power. So some component of explosiveness. So ways to, prescribe power is that you can increase the force over a given distance, but don't let them have any more time, right? That would increase power. Or you can do the same force and then just shorten the amount of time they have to do that activity, or all ways to kind of play with and incorporate this explosive activity. And I include this because I always feel like this is the obvious, the athlete who needs power, but just to always keep in mind that functional activation does require a speed element if you want to be able to do things in a timely manner and participate in kind of the natural world safely. So we'll end with this last concept. We've talked about how you choose your muscle activation, You choose your initial load by what they can currently do and what your goal is for that patient. And then you strengthen them over time by progressively increasing that resistance exercise. You continually overload the muscle as strength and endurance improve. And the classic story is the cartoon, which is Milo and the calf, where the boy is going to carry his calf to the market every day, I believe is the story. And obviously he can easily throw this calf over his shoulder, and he carries it every single day. And because the calf gets slightly bigger every single day, the load increases subtly every single day. And because he's progressively increased that load, the Milo, the kid carrying the calf, has also grown in response to the load. And now he can carry a bull over his head because he very slowly and systematically increased that load and provided progressive resistance exercise. So as it says in your notes, we need to increase the weight to continually have overload. Weight should increase by about 2 to 10% as soon as the desired number of reps with the current weight is exceeded by 1 to 2 repetitions. So that is kind of an easy, all-purpose guide, right? As soon as they can, with the weight you're prescribing, do 1 or 2 more reps than you think should be their limit, they need a higher amount of weight and you bump it up. There is much more uniform recommendations. So I have these in here. Do not memorize them. It's just helpful to see that if you don't feel comfortable with that kind of continually assessing your patient and feeling confident that you would progress them over time, there are some recipes. Kind of DeLorme's PRE is from Dr. DeLorme. He was really the first one that introduced this progressive overload. And you can see he recommends 3 sets, and the load gets progressively higher as you go through. So the benefit here is this kind of builds the warm-up right into the conditioning phase. And it's all given as a percent of 10 rep max. So you do 10 reps at 50%, another 10 reps at 75%, and then 10 reps at 100% of your 10 rep max. And then as you go through the protocol, you continue to add weight so you're successfully achieving that 10 rep max. Another really popular kind of prescription for progressive resistive activity is the daily adjustable progressive resistance exercise, or DAPR. This has 4 sets, and it allows you to adjust the weight based on the performance of that very day. So first set, you do about half your working weight, you do 10 reps. Second set, about 75%, 6 reps. Third set, you go to your full weight, the full load that you want, and you do the maximum number of sets possible. Whatever they accomplish in 3 will inform what you do in 4. So in the third set, if they only get 2 reps in, you have to decrease the weight and repeat. If they get 5 to 7, you are right in the sweet spot. You keep it the same. If they can do 8, 12, greater than 13, you want to bump that weight up. So it kind of builds in the resistance based on what you do in the third set. And then whatever happens in the fourth set is how you adjust for the next day when you're doing the next time you're doing the same load in this muscle group. So again, if your reps are very, very low, you would decrease the weight. If your reps are very, very high, you would increase the weight. All of this is designed to ensure that you're getting progressive overload, that you're constantly pushing that muscle beyond what it's capable of doing now, but not so much that you're causing any kind of damage. Okay, so this is kind of an underlying problem with our patients in the fact that their comfort zone does not overlap with where physiological adaptation occurs. And we have to be able to educate our patients on the benefits of exercise and the exercise prescription, on what is the physiological adaptation that we're going for. Why do we need to get them so far outside of their comfort zone to make a change? Why can't they just use their arm a little bit more around the kitchen and have their rotator cuff get all better? We need to have a really good understanding of how, if we prescribe an exercise appropriately, we make change. All right, we're going to end it here, and we'll pick up in our next lecture on what is the physiological response when we are successful at this goal, when we prescribe exercise to induce that change. Have a good day, everybody.